with disabilities, also known as PWDs, have been disregarded on a usual basis, and even more so during the pandemic. The United Nations states that PWD includes those with long-term physical, mental, intellectual, or sensory impairments. These impairments can then hinder their participation in society. In this definition, we note that someone with a temporary injury is not considered a PWD. Furthermore, disability can manifest in different forms, and we need to consider all forms of disabilities. Moving on, our team has researched some current measures put in place to help the PWD population in Fiji.
Firstly, there is a Fiji Disabled People's Federation survey team made up of PWDs themselves, and help to find out the current health and economic status of PWDs. This organisation will be a useful partner for our interventions. Secondly, the National Council for PWDs Complex has launched services, websites, and more which help to raise awareness of the issues affecting PWDs. Thirdly, PWDs in Fiji have a guaranteed right to employment and have also been more engaging in decision-making, showing that there is progress towards integration of PWDs into their society. However, despite all these current efforts, PWDs are still facing various issues which in turn affect their pandemic preparedness, and this will be explored.
Our focus will be on PWDs living in urban areas in Fiji. The rationale for this can be seen using the social model of disability. This model shows us that PWDs face physical barriers, social and cultural barriers, and institutional barriers. Physical barriers occur when their disabilities prevent the access to their surrounding physical environment. This includes all forms of infrastructure, such as public transport and health centres, mainly due to the lack of PWD-friendly infrastructures. This barrier was heightened during the pandemic lockdowns. The social and cultural barriers that PWDs in Fiji face include stigma, discrimination, and abandonment by the community. PWDs commonly face discrimination by healthcare personnel, resulting in exclusion from treatment. This barrier needs to be addressed for PWDs to integrate with the community and access services without being discriminated against. Institutional barriers that PWDs in Fiji face are the poor implementation of legislations and a lack of consultation to promote their rights and address their needs. Furthermore, PWDs are more likely to be engaged in informal work and have less access to labour protections. This puts them at a more vulnerable situation during the pandemic, where the economy will be impacted. Thus, we have shaped our pandemic preparedness plan to address these barriers. Specifically, our group will target the PWD population in urban areas. The reason for this is that more than half of Fijians live in urban areas, hence we would likely have a feasible population size of PWDs to work with there. Additionally, since specialist health in Fiji tends to be located in urban areas, we will be able to obtain more PWD patient data. We plan to run this as a pilot study and evaluate its effectiveness with hopes for future work in rural areas.
This theory of change will explain how we plan to improve pandemic preparedness among PWDs in Fiji. So this is the current situation, and this is our desired change. In order to achieve our desired change, we need to enhance surveillance systems, improve quality of existing facilities and services, and mitigate barriers to health services. In order to bring about these changes, we also need to improve accessibility to PWDs, address their needs, and reduce stigma towards them respectively. Our group has come up with 3 interventions: mobile PWD events, PWD-friendly facilities, and PWD campaign, which will be discussed in detail.
Our first intervention considers both mainstreaming and targeting and aims to remove social and institutional barriers faced by PWDs. To improve accessibility of health services for PWDs, we first intend to engage and train volunteers from organizations like the Fiji Disabled Persons Federation and healthcare workers through workshops on interacting with disabled persons and removing the stigma surrounding them. The objectives are to establish an understanding that PWDs are a heterogeneous group and that individuals in each group use different strategies to interact with others. More importantly, we hope to foster respect for the individual autonomy and independence of PWDs while removing harmful stereotypes. Upon completion of the training, we plan to send out mobile vans to different provinces fortnightly to provide basic health checkups, screening, monitoring for disease symptoms, vaccinations, and medications free of charge. Each province will receive the van once per month. These vans can be used as a platform to reach out to PWDs in future pandemics, where basic health services are adapted to more pandemic-focused ones should the need arise, and would be useful for early case detection. We also plan to conduct regular needs assessments to improve current measures and find new solutions. It also acts as a feedback channel for PWDs to express their concerns. This inclusivity can aid in the interactions between PWDs and the workforce. This initiative can help to reduce healthcare costs, including unnecessary visits to the emergency department and its associated reduction in hospitalization and readmission rates. We plan to use the number of PWDs that the mobile vans manage to reach out to as a measure for its effectiveness. However, we anticipate that this intervention would require extensive connections with healthcare providers and hence difficulties in tracking successful patient referrals and low patient follow-up. We also expect logistical challenges like recruitment and retention of experienced healthcare workers and volunteers.
Our next intervention aims to remove stigmas with PWDs. Previous studies by the CDC shows that stigmas tempt people to hide symptoms or illness in the pandemic, keeping them from seeking healthcare immediately and prevent individuals from adopting healthy behaviors. Thus, breaking stigmas, especially related to PWDs, is essential to control the spread of an outbreak. Before all else, we recognize anti-stigma campaigns are not races, but marathons. We have to build consistency and show reliability to build a brand and a successful campaign. Hence, it is crucial to start the campaigns early and publish contents on a regular basis. Firstly, our campaign will mainly be on the social media and television channels, as we have identified both channels have mutually exclusive target audiences, and this allows for a wider reach for a given budget. Content-wise, we propose for the Fijian government to post debunking videos regarding PWD misconceptions. This is in parallel to recommendations by the WHO. The content directions will also focus less on the stigma itself and more on creating familiarity and empathy through education and the community stories of the community. The target reach of the campaign is 1 million subscribers cross-platform. The target conversion rate is 10% of people in the community who are neutral to discriminating PWDs to the opposite end across 2 years. With a budget of roughly $30,000 per annum, this comes to 35 cents per subscriber. To realize the project, we plan to first conduct a root cause analysis with the stakeholders to discuss and finalize on the campaign directions, then launch a 3-month pilot program. Should the program be on track with the target reach and target conversion rate, the account will continue to be used for 1.5 years with monthly progression tracking. Past the 1.5 years, it is our decision whether to renew it. By doing so, we created a channel for people of all echelons to connect with PWDs, breaking stigmas, and overall increasing their confidence in seeking help, as well as the willingness of community to provide help.
Our final intervention in the course of improving pandemic preparedness among the PWDs is developing and enhancing PWD-friendly facilities in hospitals and quarantine facilities. This is to ensure that PWDs have equal access to healthcare services and facilities in the event of a pandemic, and their rights to basic healthcare is not neglected during times of crisis. Our scheme of plan is as follows. To enhance mobility among the PWDs, ramps will be built along the hospital entrance and exits, as well as in any floor that has differential elevation. Handrails will also be constructed to ensure the safety of the PWDs. Every hospital or quarantine facility will also have elevators as the main mode of commuting for PWDs. To ease the PWDs' navigation across the hospital or facility, instructions will be put up in braille, tactile or audio forms to cater to the visually impaired and signages for the hearing impaired. The existing main doors to the hospitals will be replaced with automated doors to ease the movement of the PWDs. PWD toilets will be built in each level in the hospital with toilet and washroom facilities in the same unit. These toilets will also have wide enough doors for wheelchairs to enter and hand railing for better support. An alarm system will also be installed in enclosed places such as elevators and toilets to ensure that the PWDs can call for immediate help in the event of an emergency. The hospitals and facilities will also revamp the floor to non-skid flooring and have designated PWD parking slots. Additionally, the rights of PWDs living a quality life shall be protected through the implementation of disability policy that seeks to offset a portion of their medical bills, as well as provide support services such as counseling and psychological first aid. This is a sustainable intervention as these PWD-friendly features are not only effective in enhancing the pandemic preparedness but improves the overall quality and accessibility to healthcare services at normal times. This intervention will also be receptive among the PWD community as it directly benefits and eases their healthcare experience. Along the course of 2 years, the PWD-friendly features will be installed across 3 hospitals in the central region and 3 hospitals in the western region, which is logistically and financially feasible. Thus, the effectiveness of this intervention is expected to be high in the long term.
Now moving on to timelines for each intervention. For the mobile vans, PWD dense areas and the intended travel routes will be mapped out in the first month. Months 2 to 4 will be used for setting up administrative systems, procuring logistics, developing training materials and hiring the necessary staff and volunteers. After 2 months of training, the mobile vans are ready for operation. Every 6 months, the vans will be based at a different location, during which they will operate continuously for 1 week each month. Next, the research, ideation and discussion of campaign direction will occur over 3 months alongside the hiring of the campaign team. The materials will be developed over the next 3 months before fully launching for the remainder of the 2 years. Lastly, the timeline for PWD-friendly centres starts off with an assessment of existing designated isolation centres to identify gaps, before establishing a system for collecting disability disaggregated data, procuring logistics, hiring staff, and developing training materials over the next 5 months. After equipping the centres with PWD-friendly features, staff training will take place for 4 months, and these newly upgraded centres can then open for operations in the last 8 months, even during pre-pandemic periods, so that their quality and capacities can be tested and improved when utilised in response to local outbreaks such as leptospirosis. This chart here provides a simple summary of major phases in our proposed 2-year program.
Our plans utilize the $200,000 budget as follows. Firstly, $12,000 is allocated for the training of nurses and drivers who will be manning the mobile vans, while $30,000 is allocated for equipment and logistics costs, which includes the purchase of vans as well as portable equipment for screenings. $18,000 covers vehicle operations, which includes fuel costs as well as vehicle repair expenses. And lastly, $10,000 is allocated for clinic operations, which includes medical waste management. For the campaign, $10,000 is allocated for equipment costs, which includes filming equipment, design softwares, as well as social media platform fees. $60,000 is allocated to manpower costs, which covers project managers, campaign strategists, and the rest of the social media team, such as copywriters, designers, and videographers. Lastly, $50,000 will be used to upgrade and install various kinds of PWD-friendly features at designated isolation centers, while $10,000 is set aside for policymaking and staff training to provide psychological and financial aid to PWDs.
As we have all seen over the past 2 years, COVID-19 has evidently demonstrated how the same worldwide disaster tends to impact persons with disabilities in a disproportionately worse manner. With our comprehensive 3-pronged approach, Fiji's pandemic preparedness will be holistically enhanced through improving case detection and healthcare accessibility among PWDs, combating the stigma against them, and developing PWD-friendly isolation centres.